We'll start with our first session of multiple sessions of short talks regarding abdominal imaging pathologies. Our first talk will be with the amazing Dr. Shaunam. She will talk to us about the radiology of gallbladder common pathologies. Whenever you want the next slide, just tell me next slide, okay?
First of all, a brief review regarding the anatomy of gallbladder. Gallbladder lies in the right hypochondrium in the inner surface of the liver between segment 4 and segment 5. It divides into fundus, which is the most inferior part of the gallbladder, and body and the neck. In the region of the neck, there's a small pouch called infundibulum or Hartmann's pouch. It's a common site for gallstone infarction. And gallbladder is connected with the cystic duct to the common hepatic duct to form the common bladder. Blood supply of the gallbladder is by the common hepatic artery. Function of the gallbladder is like as a reservoir of the bile, and it contracts in response to fatty food in the digestive tract. Regarding the first disease of the gallbladder, gallstone disease, gallstones is one of the most common findings of the ultrasound in daily practice. And the common risk factors for gallstone including increasing age in both genders, female gender, obesity, diabetes, and pregnancy. There are 4 types of the gallstones: cholesterol, which is the red type, mixed, which is the most common type. About 75 to 80% of the gallstones are mixed type and contain about 50% cholesterol or 50% of calcium bilirubin. And the pigment stones, which may be black pigment or brown pigment. Black pigments are more common, about 20% of the gallstones, and seen in patients with hemolysis, cirrhosis, or malabsorption. And brown pigments seen in patients with infection. They are less common, about 4.5% of the gallstones. Next slide. Regarding the gallstone-related disease, gallstones may be present, but they are not causing any disease. In this time, they're called asymptomatic cholecystitis, which may be about 80% of the gallstones and found incidentally on the imaging, or may be symptomatic in about 20%, which is the patient present with the right hypochondrial pain in response to eating fatty meals. This pain is subsided within 1 hour. If the pain lasts for more than 6 hours, it means complications that may be happening, like acute cholecystitis. Complicated cholecystitis, symptomatic patients have a risk of 1 to 2% per year of developing complication. And later on, I'll talk about the complications in the detail. Regarding the imaging features of the gallstones, ultrasound is the imaging technique of choice and has a sensitivity of about 84% and specificity of 99% diagnosis of gallstones. On ultrasound, gallstones appears as echogenic foci with posterior acoustic shadow. The posterior acoustic shadowing is seen regardless of the composition of the gallstones. And when we see the gallstones, you may ask the patient to turn on the side, or examining the patient by the neck position, if the stone will be changing its position. And this sign is called the rolling stone sign. It has a benefit for differentiating the stone from other causes of echogenic foci within the gallbladder. Multiple gallbladder stones may obscure the posterior wall of the gallbladder, like this picture. In this situation, the anterior of the gallbladder will be seen, and immediately there's a line of echogenic foci. After that, there's a posterior acoustic shadowing, and the posterior wall of the gallbladder is missing. In this situation, maybe diagnosis is difficult to differentiate from the gas within the duodenum. And this pattern is called wall echo shadow, and it's seen in patients with multiple gallstones.
So this is the wall, this is the echo, and this is the shadow, okay? It's how to differentiate from the duodenum, changing the position. So when you see this wall, echo, shadow, you need to think of gallbladder filled with stones, okay?
Regarding the completed tomography, the sensitivity of CT is less than that of the ultrasound because CT depends on the matrix and the size of the gallstones, and has sensitivity ranges from the 55 to 80%.
What do you mean the matrix?
calcification because we said there are
matrix of the stone,
yes,
because there is matrix of the CT scan itself.
No, I mean the
The
matrix
stone, the composition of the stone itself. If it is not if there is no calcification or no calcium within it, it will not be seen. You'll see a normal gallbladder. By ultrasound, you'll see a big stone. By CT, nothing. So not CT is a bad modality for gallstone diagnosis.
Like in this picture, the well-calcified stone is seen here in the CT scan. But in the next slide, there may be also stones with other conditions, for example.
What's here?
These are stones, but they are not well calcified.
What's the content here?
And it may be happens with mucousy and
these are fat or cholesterol containing, let's say cholesterol containing.
But also the inside the bowel they are visualized because of fat content.
Because they are the same density of this fat. You see, this is the same as this. Because these stones are cholesterol stones, while here they contain calcium. Okay? Excellent.
Regarding the magnetic resonance cholangiopancreatography, the common bile duct stones happens in 10 to 20% of patients with symptomatic gallstone disease. If ultrasound shows dilatation of the bile duct and intraductal echoes, the probability of common bile duct stone is increases to 45 to 85%. So in patients with intermediate probability of common bile duct stone, in which there will be rising alkaline phosphatase in the biochemical test and dilated CBD on ultrasound, preoperative MRCP is indicated. And the MRCP is high sensitive for detection of the common bile duct stones, about 90 to 95%, and highly specific, 95 to 99% for detection of the common bile duct stones. They appear as a low signal intensity, like a filament defect within the common bile duct, and surrounded by hyperintense bile. The complication of the gallstones, the first one is acute cholecystitis, acute gallbladder wall inflammation. Later I'll talk in details in the next slide. And Mersey's syndrome. Mersey's syndrome is caused by extrinsic compression of the common hepatic duct by the stone, whether it's impacted in the neck or in the cystic duct or in the Hartmann's pouch. There will be dilatation of the common hepatic duct, like in this MRCP view, and by the stone which is in the cystic duct here.
This is the stone. Okay. So the stone compresses on the common hepatic duct, causing intrahepatic dilatation. The stone is in the gallbladder, but it compresses on the. صح? No.
Another complication of the gallstones is called cystoenteric fistula gallstone ileus. When large stones are present in the gallbladder for a long time, chronic irritation and inflammation of the gallbladder wall cause a perforation and fistula formation between the gallbladder and the bowel. The large stones may also occlude the ileocecal valve, which causing gallstone ileus. We found on the imaging air in the biliary tract and dilatation of the small bowel, and there will be a dense, bright shadow in the region of ileocecal valve. This trait is called regular trait. It's for diagnosing of gallstone ileus. Another complication of gallstones is gallstone pancreatitis, when small stones passing down in the common bile duct causing occlusion of the pancreatic duct and subsequent pancreatic happen.
You can see this pancreas is edematous. The surrounding fat planes are edematous due to pancreatitis secondary to gallstone in the ducts.
Acute cholecystitis is most commonly caused by the stone, which in this time is called calculus cholecystitis, and it develops in 6 to 11% of cases of symptomatic gallstones, and more common after the age of 50 years old. It's more common in the female, twice common in the females, but if it happens in the males, it's more severe. The other risk factors for calculus cholecystitis include obesity, diabetes, and certain drugs like those patients taking oral contraceptive pill or hormone replacement therapy. Calculus cholecystitis only account for about 5 to 10% of patients with acute cholecystitis.
Just one note, when you write acalculus, it's one word. There is no space. Okay? Now this is a calculus. So this is stone. Okay? So you have to be sure to know there is no space. It makes a big difference. Anyway, it's understandable. No problem.
It's commonly seen in men and hospitalized or critically ill patients. Other risk factors include diabetic, major trauma, and risk of total parenteral nutrition, recent bone marrow transplantation, and disorder, major vascular injury, surgery. The imaging features of acute cholecystitis: ultrasound is the imaging investigation of choice, has sensitivity of 88% and specificity 80%. Ultrasound diagnosis requires at least one of these two features, in which the gallbladder wall thickness more than 5 mm, and sonographic mortis sign. When the gallbladder is distended and we put a probe, this elicits the pain because of the stretching of the nerves in the gallbladder wall. It's more sensitive than the clinical Murphy's sign. Other features that we may see in the acute cholecystitis on imaging, specifically on ultrasound: gallstone up to 98%, enlarged gallbladder, the longitudinal diameter more than 8 cm and the transverse diameter more than 4 cm, and pericholecystic fluid and gallbladder wall edema. And this time we may see a trilaminar gallbladder wall in which there will be an eco-lucent layer between two echogenic shadows. It's called trilaminar gallbladder wall.
Just like that.
And increasing Doppler sign from gallbladder wall. The second imaging investigation of choice in diagnosis of acute cholecystitis is hepatic immunodiagnostic acid scan. It's performed when ultrasound is equivocal. Normally, when there is normal cystic depth, when we inject radiotracer, the gallbladder will be seen after 30 minutes. In patients with cystic depth obstruction, the radiotracer will not be seen in the gallbladder after 30 minutes. We may inject morphine to contract the sphincter of Oddi and increasing intrabiliary pressure. If after 30 minutes after injection of the morphine still we didn't see the gallbladder, diagnosis of acute cholecystitis. Magnetic resonance cholangiography in case with acute cholecystitis performed with complications suspected, especially in common bowel Gallstone. Some surgeries are prefer to do it before the operation to exclude the common bowel Gallstone because there is a risk of 10 to 20% of common bowel Gallstone that may have the gallstone disease. CT scan performed also when complications are suspected and show signs of acute cholecystitis when the gallbladder wall more than 4 mm, and calculus is radiopaque, and pericholecystic fat stranding.
Okay. You can see the pericholecystic fat stranding and the edema of the wall of the gallbladder. Okay?
Mucocele, it may also happen as a complication of the gallstone, or it may also happen as when the presence of a tumor or an extrinsic compression causing a cystic duct obstruction. Pigment and bowel gets absorbed, then the gallbladder is distended with the mucoid material. On ultrasound, it shows distended gallbladder with obstructing calculus also may be seen. When, as I said, maybe happens to the other cause, for example, obstructing tumor. And this time we may be ordered a CT to exclude an obstructing tumor. Empyema of the gallbladder, also it is a rare condition when the gallbladder lumen is occupied by the pus. In the imaging, we may don't diagnose it, but sometimes there may be air loculi within the gallbladder lumen that indicates suppurative infection within the gallbladder lumen. Gangrenous cholecystitis, when there is prolonged distension of the gallbladder, there will be gallbladder wall ischemia and necrosis. And it happens in about 20% of patients with acute cholecystitis. Elderly and diabetics have higher risk. On the ultrasound, we will see wall striation and infraluminal membranes.
What are the infraluminal membranes? What does it represent? From where did these membranes came?
Destruction of the wall of the gallbladder.
This is sloughed mucosa. The mucosa gets necrotic, dead, and sloughed from the lining of the gallbladder and starts floating in the gallbladder lumen. You know, it's gangrenous.
And sonographic Merkel sign may be not present because damaging of the also nerves in the wall of the gallbladder. In the CT scan, non-contrast shows hyperattenuation because of the hemorrhage, And in contrast enhanced CT, like this image, there will be discontinuous or absent in the wall enhancement because of the arterial damage and ischemia. The most common important complication of the gangrenous cholecystitis is gallbladder perforation and rupture, which is mostly occur at the fundus because of the poor blood supply. There are three types of perforation of the gallbladder: perforation with peritoneal spillage, like in this case, and subacute perforation with pericholecystic collection, and with fistula formation, whether it's between the biliary or between biliary and
and the bowel.
Yeah. Emphysematous cholecystitis can be secondary to infection by ghost-forming organism. Again, it's more common in the elderly and diabetics. An ultrasound shows highly echogenic air foci within the lumen with low-level posterior acoustic shadowing. With reverberation artifacts like here, and we will not see the continuous posterior acoustic shadowing like that of the stones, and called dirty shadowing. Another time when we ask the patient to change the position because air are going to the most non-dependent part, it's called champagne sign.
Champagne sign.
Champagne sign.
Champagne. Okay, air bubbles in the champagne goes up. You know, يعني مثل المشروبات الغازية like gaseous, I don't know, drinks, soda, and something like that. It goes up the bubbles. Okay.
In the CT scan, demonstrate air in the gallbladder wall or in the lumen of the gallbladder, like here, in the wall of the gallbladder screen. Chronic cholecystitis is the most common disorder of the gallbladder and more common in the women after 5th or 6th decade of life. Ultrasound is the investigation of choice, and it shows thickening of the gallbladder wall more than 4 mm, and small contracted gallbladder and cholecystitis.
So the trick is contracted gallbladder with signs of cholecystitis with gallstone.
Yes.
But not distended, contracted.
In MRCP, again you will see a contracted gallbladder and cholecystitis. MRCP is mostly done for exclusion of the common bile duct stone and coexistent with the chronic cholecystitis. CT has no role in diagnosis of chronic cholecystitis. Another condition of the gallbladder is hyperplastic cholecystosis. They are non-inflammatory pathologies of the gallbladder associated with hyperplastic thickening of the gallbladder wall. These are two conditions. The first one, cholesterolosis, is a diffuse deposition of the cholesterol in the wall of the gallbladder and cannot be diagnosed on imaging when it is diffuse. But when it is focal, causing focal polypoid lesions, typically are of 2 to 10 mm, and it can give rise to cholesterol polyp and can be detected. On ultrasound, you will see a small, smooth, walled hyperechoic lesion with no posterior acoustic shadowing. And also cholesterolosis is the most common cause of gallbladder polyps. Gallbladder adenomyomatosis is a common condition and has certain imaging feature. It accounts for approximately 25% of polypoid lesion in the gallbladder. On ultrasound, again, it appears as a hyperechoic shadowing within the gallbladder with twinkling or cometal artifact. On the MRI, these spaces appear as a multiple round hyperintense foci around the gallbladder wall, lumen, and its names are pure nucleus sign. Normally, there are small intramural diverticula within the wall of the gallbladder. These are called Rokitansky-Ashkov sinus. When there is hyperplasia of these sinuses or deposition of the cholesterol and calcium in these sinuses, gallbladder adenomyomatosis will be developed. There are 3 morphological types of adenomyomatosis. The first one, focal adenomyomatosis, causing thickening of the fundus of the gallbladder and may mimic gallbladder carcinoma. The segmental form results in the thickening of the body of gallbladder and results in the appearance of characteristic hourglass gallbladder. In the mid there will be constriction and two sides will be dilatation, and diffuse adenomyomatosis. Gallbladder carcinoma accounts for 1 to 2% of global cancer diagnosis, and most common types adenocarcinoma, more common in the women and diagnosed commonly after the age of 6 years. The risk factors for gallbladder carcinoma include gallstone disease, porcelain gallbladder, gallbladder polyp, primary sclerosing cholangitis, chronic biliary infection, and anomalous biliary junction and obesity. Porcelain gallbladder, when there is chronic cholecystitis, calcification of the wall of the gallbladder, moral calcification called porcelain gallbladder. It has a risk for malignant change. Previously, they diagnosed that maybe 20 to 30% there will be malignant transformation in this condition. But nowadays, they found that it's less, about 5 to 7% there will be risk of malignant transformation. So, cholecystectomy in this patient is not always performed nowadays.
Yes.
The imaging features of the gallbladder carcinoma. Ultrasound can detect gallbladder carcinoma up to sensitivity of 85%. The features that are suspicious for gallbladder malignancy on ultrasound include non-visualization of the gallbladder in the absence of history of cholecystectomy, or embedded stone in which the stone is surrounded by soft tissue.
This is stone and this is all soft tissue.
Yeah.
Okay.
Irregular or nodular gallbladder wall thickening more than 4 mm, which is the most common finding, and gallbladder polyp of more than 10 mm, cell polyp or irregular enlarged nodes. In the CT scan, we need biphasic CT, and it means examination in both arterial and venous space. In the arterial, we are checking for arterial involvement within with the carcinoma, and in the portal venous space, we are checking for metastasis, especially to the liver. It's an imaging technique of choice for primary staging. MRCP is sometimes also done for map the biliary anatomy and determine the level and extent of biliary involvement. In both cross-sectional image, you should comment on the primary mass and involvement of the liver, surrounding organs, biliary, vascular, nodal and peritoneal, are also distant metastasis.
Well, first of all, the arterial and venous phases, you're correct. One of the reasons to do arterial and venous phase is to see the invasion of the arteries and the veins, but this is not the primary cause. The primary cause is most malignant tumors, they show enhancement on arterial phase, and they show wash up on venous phase. They enhance in the arterial and they wash in the venous. So if you see this lesion increasing in density on the arterial phase and decreasing density on the venous phase, it increases the probability of it being a malignancy. While the normal, for example, liver, it will increase enhancement in the venous phase. So when there is a metastasis, the metastasis will show better as dense on the arterial phase and will appear as hypodense on the venous phase. Okay? Not all the tumors, most of the tumors. For example, pancreatic adenocarcinoma, it's the opposite. It does not show enhancement on the arterial phase. I don't know why. It's just like that. Okay? So one of them is to evaluate the arterial and venous enhancement, and second, to see the enhancement characteristics of the lesion. Okay? Thank you very much.
In arterial space in our liver, because of the portal vein, because of the blood supply of the liver by vein.
Okay, so
that's why it happened.
no, it's not that. That's the enhancement characteristics. What about the renal cancer? It enhances on the arterial and wash out on the venous.
I understand in a lesion it have more artery become
enhanced on arterial.
Yes.
Yeah.
Like that?
Yeah, it's just like that. Just only in the pancreatic adenocarcinoma, I don't know why, but it shows enhancement in the venous phase, not in the arterial phase.
Why?
I don't know why. The first thing I said, I don't know why. Okay, so it's like a common trick question. They ask you, what about pancreatic adenocarcinoma? It enhances arterial. No, it doesn't.